Well, welcome everyone to the 27th Degree with Chris and Nancy from 27 Degrees Consulting. We're really thrilled today to have Dr. Brenda Roy with us, a gynecologist. And we're going to talk a lot about women's health. And I'll talk a bit also in a minute about her background. But before I do that, let me just mention our sponsor, Bay Coast Bank. We're always appreciative to Bay Coast Bank for supporting these efforts. Bay Coast Bank is just right for all of your financial needs. Visit baycoastbank.com or call 508-678-7641. So thank you for joining us today to talk a bit about women's health and women's issues. Before we get into this, let me tell the audience a bit about your background, because I think it's really impressive and it's good for them to hear.
Thank you. Thank you for having me.
Yeah, no, you're welcome. Thank you. So Dr. Roy is a board-certified specialist in gynecology and women's health. She is a graduate of the University of Toronto School of Medicine and completed a residency in obstetrics and gynecology at McGill University in Montreal. And McGill, for those who may not know, is like the Harvard of Canada. It's a great, it really is. It's a great university.
It was a great school. Yeah, great training.
Prior to entering medical school, she had already earned a master's degree and PhD in physiology at Queen's University in Ontario, also another great school. Dr. Roy's practice focuses on gynecological care for adults, adolescents, and children. Her particular interests include women's health, menopause management, pelvic pain, fibroids, endometriosis, pelvic prolapse, and incontinence. She provides birth control counseling. She is skilled in laparoscopic minimally invasive surgical techniques and is a member of the American Association of Gynecological Laparoscopists. This is a very hard word to say.
It is.
Yes,
It's
it is.
tricky.
It really is. That's a tough
It
one.
is.
And Dr. Roy provides genetic counseling to appropriate individuals with female malignancies. She's an assistant clinical professor of OBGYN at Brown. She's practiced at Women and Infants Hospital in Providence and at St. Anne's Hospital and joined Primacare in 2014. Dr. Roy is a fellow of the American College of Obstetrics and Gynecology and is a member of the Royal College of Physicians and Surgeons in Canada and the New England Obstetrical and Gynecological Society. She has published extensively in medical literature and has presented widely at national meetings and has served on a number of local and national professional committees. Did I say anything there that was not correct? Sound good?
No, you are correct. Yeah.
All right. Well, great. Well, thanks for being here with us. We're really appreciative of this.
Thank you.
So we can get right into this.
Sure.
And Nancy, you probably want to start off with, you always like to start off with a question, so go ahead.
Well, thank you.
I've done enough talking already.
We know who the boss is here.
I evidently, yes. So I usually will ask us, our guests to tell us a little bit about themselves. So what I wanted to ask you is why OBGYN? Like why your interest in that field?
I really like the surgical aspect of gynecology. I just recently got certified for robotic surgery at St. Anne's Hospital. So St. Anne's has a really blossoming, great robotic program. And I just saw the advantages of robotic surgery and I wanted to get on board. And it's just really is a wonderful tool for the surgical aspect, any surgical issues that women have as it relates to
That's great.
gynecology.
I'm so glad we're getting a chance to talk about women's health. Dr. Joncas snuck in men's health.
I did, yeah.
Before I got to the women's health.
Yeah.
But
That was an interesting talk, and
it
I'm sure
was
this
very
will be also.
interesting. Yes, but now we're on women's
Right.
health.
So you can take the lead on this one. I'll throw in my little questions here and there, I'm sure. You'll
Okay,
have more.
perfect. So just starting with women along the spectrum, if we think of your youngest patient to your oldest patient, can you kind of walk us through that spectrum of the different ages?
Like what
and
they might
age
be
groups and
might
what
be
their,
important for.
Sure.
what their
for their
focus
health?
should be.
Sure.
Right.
So women don't need to see a gynecologist for their PAP until they're 21 years old. So this is when we start screening for PAPs. However, women come earlier, young girls, for abnormal uterine bleeding who may not be sexually active. So that is some of the spectrum that I see in the younger girls, abnormal bleeding or with birth control. Reproductively aged women, again, birth control, any pelvic pain, any endometriosis, cervical screening. At 40 is when we start our mammograms, so breast screening. And then I see women again, the perimenopausal period, the menopausal period, and postmenopausal.
Can I ask a question just about the initiation of pap smears? You had mentioned 21 as the age. If a woman is not sexually active, though, that can be put off, correct? Or
It can be, yes. So she's not sexually active. I always ask if they've had the HPV vaccine, because that's also very important, because that is not through penetration, it's skin-to-skin contact, how
Okay.
HPV is transmitted. But yes, it's a discussion with women that we have. I mean, some women are virginal and they're just, I would like my PAP. Others we can defer, so it's always a conversation.
Okay.
Can you talk a little bit about HPV?
Yes. So HPV is the virus that we know causes cervical cancer. So, in my opinion, and you may know better, there's very few cancers that we know exactly what causes it.
Right.
And HPV has a very strong link to cervical dysplasia. So, a dysplasia is a precancerous lesion. We usually catch cervical dysplasias with the pap smear because it's cervical screening. And the precursor is the human papillomavirus. And there are approximately 200 strains of HPV. And the Gardasil, or the HPV vaccine, will protect young women. But they can get their HPV vaccine up until the age of 45. So it used to be in the mid-20s, and they've extended it to 45. So the Gardasil will protect women against HPV 16 and 18, and those are the most malignant strains of
subtypes, the
HPV.
16
Yes,
and
the
18,
subtypes,
right, yeah.
exactly right. And they cause the majority of cervical dysplasias and cancers. There are other lesser-known players that are still malignant that can cause malignancy. HPV 6 and 11 causes genital warts, so the vaccine also covers for that.
Okay, great. So just looking at that, we'll start with, I guess, the youngest age group, and maybe we can talk a little bit about menstrual flows and initiation to all that. And there were two things that I kind of wanted to cover in this age spectrum. And one was just what are some of the things you can do when you have it? I'm sorry, this is not a talk that you're going to be very interested
No, I'm
in
interested.
as far as
I have two daughters, so.
okay, as far as menstrual pain and the cramping
Yes.
and just like those really bad periods, what can you do past like heating pads and
Sure, that's a
Motrin?
great question. So the cramps are caused by a substance called prostaglandins, and they cause contraction of the uterus. NSAIDs, so Aleve, ibuprofen, they stop the production of prostaglandins. So what I tell young girls is, if you know when your period is coming, start taking the NSAIDs before the pain starts. Because once those prostaglandins are in the pelvis, it's hard to stop the production of it. So I find that works for pelvic pain.
Nice. All right.
That's good to know.
Yeah. And it was interesting. I'm very close to a couple of my nieces that are on the younger spectrum of that and just getting introduced to some of these things. And sometimes, like with health class now in schools and stuff, they miss that whole talk. So as a mom or someone who's close to a young girl going through her first couple of periods, where are the resources for those kind of discussions, and like how old do you start with that discussion?
So I mean, it's always a discussion between like the parent. Is that what you mean,
Yeah.
the parent and the
Yeah.
child? Yeah. I mean, when the maturity level is for the child, you always want to start the talk about menstruation, before
Right,
menstruation occurs. So for some women, or for some young girls, it can be around, 8 or 9 with the breast development.
That's young. Huh?
It's
young,
yeah.
yeah.
With the breast development, And then
Yeah.
the periods, it's usually 12
Yeah.
is the average age. But the menstrual cycles they're going to be abnormal for the first 5 years. So that's
Really?
to be expected, because it takes around 5 years for the brain to talk to the hypothalamus, to talk to the pituitary, to talk to the ovary, and then that feedback. So it does take a good 5 years. So it's not unusual that the cycles could be irregular at that point.
Okay.
However, it doesn't mean that it's not bothersome.
Of course.
So it's, see your gynecologist. Girls can be put on the birth control pill.
Yeah.
Not for birth control, but to
Right.
regulate the cycles. And, I ask girls and their moms, are you missing school? Are you missing social events? Are you missing your sporting events? And if the answer is yes, then that's an issue, and, we need to treat.
Yeah.
What age would you be concerned if someone hasn't gotten their period?
So that term's called amenorrhea, and there's primary amenorrhea, and then there's secondary amenorrhea. So primary amenorrhea is when they haven't had their periods. Usually at around, in the later teens, I'd start investigating.
Yeah.
And what would be the causes of a woman having primary amenorrhea? Just so the audience understands.
Sure. Some of the causes can be like a low BMI.
Okay, so body mass index as well.
Yes.
So someone who's a,
Super athlete.
so yeah, incredibly athletic, or
Right.
maybe restricting their diet quite a bit. Someone
Correct.
has an eating disorder,
Correct.
potentially, those
Yeah.
would be issues.
Yeah. And then there can be thyroid issues.
Mm-hmm.
Then we can get into like some chromosomal abnormalities, also, endocrine, thyroid, prolactin. Then you'd also like to look at the reproductive tract to make sure that there's no obstruction.
Okay.
Right. What are some of the questions that like are common for you to get from your younger clientele? Like, what do they wonder about, or is this normal, or is that normal, or am I, should I worry about this or that?
The questions that we get is regarding menstrual flow.
Yeah.
What is normal and abnormal? So over 7 days of flow would be considered abnormal, or if they're in the later teens and the cycles have already started to become regular, and then they get irregular. That would be a concern also. If they're passing clots, and again, if they're missing school, if they're missing social events, it's
Poor little tykes.
they're young. They should be.
Yeah.
Sure.
It's the last thing on their mind.
Right.
Right.
Is any age too early to start using tampons versus pads?
No, it's her comfort level.
Okay, perfect. So when we talk just in general about health and women's health, there's so many products out on the market. Can we talk about some of those? Like, we've heard some discussion on powder and
You're
douching.
talking about like vaginal
and
products.
all that.
Yeah.
Yeah.
Yes. So that is a conversation I have every day, all day long with my patients. So a lot of them have, the vulvitis, so the itchiness. So when they're younger, the abnormal discharge, it has, it's malodorous or it's itchy. And the first thing I ask them is, what are you using to clean down there? And
Yeah.
so they just have a laundry list of, I'm using this from over the counter. I'm using, powders, baby wipes.
Yeah.
And I just tell them, just water. All you need is water. And what they tell us in conferences, if you wouldn't put it in your eye, don't put it down there.
Oh.
That's a good way to look at it.
Yes.
And not to get off the subject a little bit, but one of my friends doesn't even shower with soap, and don't laugh, but she uses these special washcloths with a silver component
Oh, really?
in them. So I
Never
don't
heard
know.
of such a thing.
But
Interesting.
just getting back to some of the vaginal products. So the pH balance is kind of important to maintain, and some of these products will kind of mess around with that, right?
Yes. So your body will take care of itself. So there is a natural flora in the vagina, and there's healthy bacteria. So when you're using products, you cause an imbalance, and then that can cause the itchiness, and that can cause the vaginal discharge.
How do you know if your discharge is normal or not?
If it's more than usual, like it's copious, or if
Yeah.
it has an odd odor to it, or if there's itchiness.
Now, what about clothing? I've heard like cotton underwear.
Yes, cotton
like
underwear is
best to
best.
use.
Yeah, and just make sure that what you wash your underwear with is fragrance-free, dye-free.
Okay.
Oh.
Yeah.
Now, what about like all the waxing and everything else that people
grooming.
go for? The grooming, the landscaping. Any like you have to be careful with that.
Yeah, so we recommend clipping.
Yeah.
Sometimes in my practice, I'll see like folliculitis, which is just like a little infection in the hair
Yeah.
follicle, which can occur with
Like
shaving.
the little bumps.
Yeah, little bumps.
Yeah.
So we just recommend just clipping.
Okay.
All right. Now we're gonna jump over to menopause.
Okay.
So
You skipped everyone in between.
menopause is important to me.
All right, we'll do menopause, then
We'll go back. So tell me about okay, I think I'm starting menopause now. Like, what's happening to my body and what am I feeling like?
So menopause can have a range of symptoms. So we define it as 1 year of no periods.
Okay.
So that is the definition. So it's a retrospective diagnosis.
Okay.
And there really is no test that we can do that's going to predict menopause or if you're in menopause. So track your menstrual cycles, and then when you've gone 1 year of no menstrual cycles, that's menopause. Any bleeding after that needs to be assessed by a doctor. That's considered abnormal.
And what would cause bleeding after the fact? Is that when you're doing some of the cancer screenings?
Yeah, so always on our radar is uterine cancer.
Yeah.
And when I have some of Dr. Joncas's patients that come and see me, that he refers me to, and I tell them, it can be a number of things. It can be due to dryness. It can be due to something structural inside the uterus, like a polyp. I said, but I have to rule out cancer. I said, Dr. Joncas will never forgive me if I miss a cancer.
Yeah, anyone who has postmenopausal bleeding that I see, they immediately go
Yeah.
for a gynecology evaluation because it's always the concern you need to rule out.
Yeah, you need to rule it out. Yeah, absolutely.
You said something interesting about the hormone test. So I do order those sometimes if someone asks me to, if they think they're, perimenopausal, I'll get an estradiol and a follicle stimulating hormone, a luteinizing hormone. Is that really not worthwhile doing?
Yeah, if they're younger, like 35 to 45, I will do it because there is such a thing of the premature ovarian failure.
Sure.
If the FSH is elevated and the estradiol is low, and they're starting to have hot flashes. Because then hot flashes can be from other things, such as the thyroid.
Sure.
But that is the one time where I would yes, I will do.
But otherwise, just follow how long has it been since they've been without a period, and after a year they're postmenopausal. It's more of a
Correct.
historical look back.
Yes.
Yeah, that makes a lot of sense.
Yeah.
So these hot flashes, I mean, I feel like I bought stock in every fan company that's out there. Is there, what can you do?
All right, so that's a great question. Lifestyle modification is always first line we come to treat in medicine. So keeping the ambient temperature at 67 degrees, dressing in layers, avoiding some of the triggers of hot flashes, which can be spicy foods, alcohol,
Of course.
hot beverages, stress, if you can avoid it.
That's an easy one.
That's an easy one, yeah. Especially in this day and age, right? And then we can get into some of the pharmacology. So over the counter, there really isn't much that's going to help. I mean, there is a placebo effect, 30%. It doesn't last forever. There are prescriptions such as Bristol, which is a Paxil, and it's 10 milligrams. It's not at a dose that's high enough to treat depression, but it is
Right.
FDA approved for hot flashes.
And
Really?
I've
That's
used
interesting.
the SSRIs a
Yes,
lot.
definitely.
And
Yep.
they do seem to help a
Yes,
little bit.
I agree. Yep, definitely.
And so you're giving me full license to keep my fan on at night, and if my husband ever complains again, I'm just going to throw him an extra blanket.
Right. So there are things that you can put on, like under your fitted sheets. There's like chili pads that can bring down the temperature significantly.
Chili
That's really
pad.
good.
Yeah.
That's a great idea.
And there's like the Chillo pillow.
Get one of
which-
those for my wife.
Yeah,
Oh.
The Chillo pillow.
Chillo pillow.
See,
It's
we're
you put it
creating
in
some
the freezer.
Christmas lists here.
That's right.
Where do you get those?
You can get the Chillo pillow on Amazon,
Okay.
and the chili pad, a company called Uller. That's one of them.
Interesting.
I like that. Pad and pillow.
I'm always amazed with the hot flashes. I have women who come in and they tell me, I've been having hot flashes now for 8 years. And in some women it's gone in a year or two. But it just seems like with others it just lasts forever.
Correct. Yes. So to finish the conversation about treatment for hot flashes, so the hot flashes are due to a lack of estrogen. So ovaries have a shelf life, unfortunately, and the average age of menopause is 51 years old.
Okay.
However, you can have the menstrual irregularities before that time. But the hot flashes can occur once you get that drop in estrogen.
Right.
So hormone replacement therapy is safe, and women, they don't need to suffer through menopause because it can last, the hot flashes, 7 to 10 years.
What was the controversy with the estrogen therapy? Like I remember hearing a lot, like pros and cons with it. So what are the
Yeah,
arguments on
another
both
great
sides
question.
of that fence?
So there was a study that came out almost 20 years ago. It was the Women's Health Initiative. And what the point of that study was, is they wanted to see if hormones were cardioprotective, meaning could we reduce the risk of heart attacks in women if we give them estrogen and progesterone? So the average age of the women in that study was 65. So what they did is they gave those women estrogen, and they found that there was an increase in heart attacks and strokes. However, we now know that there's something called the timing hypothesis, where if you give women estrogen outside of 65, older women, if they've been out of menopause for around 10 years, you destabilize the plaques that are in their blood vessels, and then they throw off thrombi. So it is safe to take estrogen early. in
Okay.
menopause.
So that's the
Yeah,
key.
that's the key,
phrase
is
there,
timing.
early.
So, don't delay, go see
I
your
always
doctor about
wondered
hot
about that.
flashes.
Yeah.
The sooner we do it, replace the estrogen. If you have a uterus, then we need to provide progesterone.
So if you get a hysterectomy, do you then have menopause? Like, suppose a 35-year-old has a hysterectomy, what happens?
Correct. So, younger women like that, we would keep the ovaries.
Oh, okay.
Yeah. So we take out the uterus. So you're right. You would not know because your uterus is gone. It would be, a different conversation as to whether you're having hot flashes. But it is safer to give women hormone replacement therapy or estrogen replacement therapy if they don't have a uterus, because you don't need the progesterone, which
Right.
protects the lining.
Oh,
Right. And then the rise in the breast cancer that was found in the Women's Health Initiative was due to a type of progesterone, hydroxyprogesterone acetate, which we don't really use anymore. That we think is what caused an increase in breast cancer, but it was a very slight increase. So we always have to, keep things in perspective.
I'm glad you clarified that because I've always been kind of confused with the estrogen. Like, is it good or is it bad? And
It's good for your bones.
Yeah.
Women just don't need to suffer through hot
But
flashes.
I don't see a lot of my patients come in that are on estrogen anymore. Like years past, there was more. It seems like it's less commonly used, in my practice at least. I'm not seeing that. Maybe in a gynecological practice it's different. But do you think it's used less than it was years back, or is it about the same?
Yeah, I think women, after that, the Women's Health Initiative study came out, a lot of women went off their estrogen.
shied away from it.
And I think maybe that kind of dogma of, estrogen and progesterone are unsafe, even though we have a lot of studies, and there are offshoots of that main study that do show that it's safe.
So now, help me to define early in my mind again. So early estrogen therapy would be, so if I'm in the middle, like if I'm on month 8 without a period and I'm feeling hot flashes, is that when I'm thinking about the estrogen therapy?
Yep. So the estrogen is decreasing, and you don't need to be postmenopausal to get estrogen replacement therapy. So you can be on the birth control pill, very low dose, one up until you're 51.
Okay.
So we can replace the estrogen. It's just be different formulations.
How about breast cancer risk with estrogen replacement? Is that a concern at all?
No, it's women who don't have a uterus and we give them estrogen replacement therapy. It's not a concern, the studies show. And it's the type of progesterone. The medroxyprogesterone acetate that I was discussing earlier is the one that was kind of the problem progesterone. But we do like to give the estrogen and progesterone on a patch, so just to bypass the liver.
Oh.
So there's different ways you can administer estrogen.
Sometimes I'll have women who come in who really aren't suffering from hot flashes, but they have more, vaginal dryness, uncomfortable intercourse
Yes.
and whatnot. You can use vaginal estrogen for that.
Correct.
Do you find that is just as effective, or maybe even more effective than the oral estrogen replacement?
So the estrogen cream just works locally in the vagina. There's very little systemic effect, so it won't help with the hot flashes.
Okay.
So it would just be for, as you said, painful intercourse or vaginal dryness. Also, when you look at the anatomy, the bladder is right near the vagina. So if the vagina is dry, the bladder is going to be dry. So our colleagues, the urologists, use estrogen cream a lot also because it helps the bladder.
Yeah, I've seen they use it a lot with women who suffer from incontinence or, a lot of atrophy.
Yeah, for urgency.
Exactly.
Yeah, and in women who have recurrent urinary tract infections, if you give them the estrogen cream, it will decrease their urinary tract infections by 50% with the estrogen.
Yeah, that's great.
So when you initially start the estrogen cream, the vaginal mucosa is very thin. So it does take a while, it doesn't work overnight.
Right.
So the dosing would be every night for 2 weeks, and then after that, every third night. And I tell them for the rest of your life, you'll be on this estrogen cream. And it does make a significant difference for women. The only contraindication would be women who have breast cancer.
Yeah.
I was going to ask you about
Sure.
that. Sure, because that comes up periodically.
It does, yeah.
Is there-
Can you use the vaginal estrogen in those cases, or you really are staying away from it completely?
Yeah, we do try to stay away from it. There is like Replens, which is over the counter, which is a vaginal moisturizer, which is different from a vaginal lubricant for intercourse.
Okay.
Since you brought up breast cancer, and it's Breast Cancer Awareness Month, can self-exams really help you pick up something
Yes,
early?
yes, yeah. So we call it breast awareness now.
Okay.
And some women will have, densities in one area of their breast and not in other areas. So it's just a good idea to know what your breasts are like, and any deviation from that, go see your doctor, and then we can do some imaging.
And that recommendation is once a year after 40, is
Correct.
that
Yes.
correct?
Yeah.
So just go see your gynecologist. Go see your gynecologist, guys, once a year.
And we were talking about this before we started, but what we've seen in medicine is because of COVID, and it's not just mammograms and that, but a lot of patients have put off their health screening. So we see, women who come in with breast cancer that maybe it would have been caught a year or two earlier, or colon cancer because they didn't get their colonoscopy. So I just want to stress as a primary care doctor the importance of going for those health screening things that you may have just put off because of all the stress of COVID and, not wanting to be in a doctor's office or a facility to get the test. But it's really crucially important. We're just seeing that people are getting diseases that they probably could have found at an earlier stage otherwise. So it's important to keep that in mind.
Absolutely.
Is there a difference between like women's vitamins and just like everyday vitamins? Like a lot of like different companies put out all sorts of over-the-counter stuff, and you never know if it's like good or not. And I
Marketing,
guess,
or if it's
yeah, and I
real,
guess
right.
it depends on the branding and stuff too. But none of those are like FDA controlled. So,
Correct.
like, what's
I think the only difference would be the prenatal vitamins. So they
Yeah.
have folic acid, which is
That's
important for
Yeah.
the neural tube development of the fetus. So if a woman is considering fertility and she's going to go off for birth control, I always advise them to start the prenatal vitamins 3 months before going off of your birth control, because you do really want that folic acid on board.
That's a really good thing to know too. How long can people stay on birth control pills?
Up until they're 51.
So you can be on them for like 20 years or 30 years,
Correct.
and
Yeah, it's all reversible.
oh, so there's no like you don't have to worry about that. There's
No,
no
you don't
kind
have
of
to take a
buildup, I
break.
guess, where you're after 20 years you're not going to get pregnant or anything.
No, you don't have to take a break from your birth control. I had a patient today who had asked that, and I was like, no, you don't need to give your body a break. You can just stay on the birth control until you're ready for fertility.
And how long do you usually? Oh, so you said you don't have to give your body a break.
No.
Like there's no. It's just boom. When I was looking at birth control, I think I was on the FDA site. Not for me, but when I was looking at the birth control handout that the FDA site offers, it had the percentage of women that would still be expected to get pregnant while using this sort of product, and they went through various different products. But I was surprised because on a lot of the birth control pills, it said you could expect 9 out of 100 women to still get pregnant, even though they're taking the pill.
Right.
That like surprised me. I didn't realize it was that high.
That seems high too.
I know it just does seem high.
Yeah. So, we'll talk about birth control.
Yeah,
That's good.
yeah.
So, again, birth control is something I see in my office all the time, and it's one of my favorite topics because there's just so many options. So there's really something for everyone.
Right.
But the first line birth control are the LARCs, so the long-acting reversible contraceptives. So those are the IUDs and the Nexplanon. So IUDs are these little devices, like a T-shaped device that has to be inserted by a doctor, and it sits in the uterus for up to 6 years. And it is greater than 99% effective.
So that's perfect. And then you're not thinking of anything.
You're not thinking
and
about it.
Do you feel it? Or is it just
Not while it's in, no.
okay?
No, it's when I insert it, it is a little crampy. It's like a
Yeah.
bad menstrual cramp.
Right.
I tell my patients to take Advil beforehand.
How do you know if it falls out? Does it not fall out? I know.
can.
Don't
No,
you
that's-
can laugh at some of these
No,
questions.
that's it's it's one of the risks of having an IUD. A 3 to 5% chance that it can be expelled.
And if you're like, we had talked about these super athletes,
Yeah.
if you're like jumping up and down and jogging and doing all these CrossFit things, is your chance of anything
No,
being
no,
displaced
no,
greater?
No, it should just stay in the uterus. It does move on its own, just by a
Yeah,
couple of millimeters,
just a little bit.
centimeters. But if a girl has or a woman has any concerns about their IUD, like all of a
Yeah.
sudden it's she has like a really bad cramp, or she
Right.
can feel the stem of the
Yeah.
IUD, just come in. You
Okay.
can always do ultrasounds.
I mean,
to
the
figure out
newer
location.
ones that are out are just so much safer than the older ones that were.
Yes,
And that's
yes.
probably important for people to know.
Yes, definitely.
Probably many of our viewers out there have experience or an understanding of what IUDs were, and it was kind of a dirty word for a while because people were getting a lot of infections and
Yes, yeah.
maybe rupture through the uterus. A lot of things could happen, but these are pretty safe now.
Yes, they're quite safe. So that was like the Dacron Shield, where they would have pelvic inflammatory disease. Now I like the progesterone-based IUDs, or there's progesterone inside the stem of the IUD.
Yeah.
And what the progesterone does is it thins the lining out, but it also makes the mucus very thicker, so that bacteria can't penetrate it. So that's why it's safer. So and it's
That's interesting.
Yeah, it's counterintuitive because the risk of PID is within the first 21 days of insertion. After that, your risk goes down.
Oh.
So the longer it's in, the less likely you are to get an infection.
That's interesting.
Now, just to clarify a point too for our viewers, the IUD doesn't serve any type of protective barrier against STDs or anything like that.
Yes, yeah, you're
Okay,
absolutely
so you
right.
still have to be careful.
Which brings me to my point that even if you have an IUD, you still need to see your gynecologist every year, because we do have to do sexually transmitted infection screening. So gonorrhea and chlamydia was just a swab, and I'll check the strings at the same time.
For the STDs, are those easily treatable?
Yes.
No. So
Yeah, so just with antibiotics, some of them are just like a one-dose antibiotic, but you want to make sure your partner's treated. And then once you have one, you're at risk for others. So I always do a blood panel, which Dr. Joncas does also. You want to test for other STIs.
Yeah, usually tests,
why?
syphilis
Why
too,
once you have one,
gonorrhea.
you're a risk for others?
Why once you have one? Well, I think
what you're saying is if you have one, they kind of can travel in pairs. So you could have chlamydia and gonorrhea. We test for syphilis. We just never see that anymore. But other things like HPV is really I guess a sexually transmitted disease in many ways, right? And
Yeah, it is.
although it's more complicated.
Yeah, it's sexually transmitted, but it's so common.
Yeah.
I mean, I tell women, 80% of women by the age of 50 are going to contract HPV, but you clear it. It's not a forever thing.
Yeah.
Smoking is the one thing that will have the persistence of HPV. So I always, smoking cessation, because smoking affects the body from head to toe, and it decreases your immunity at the level of your cervix. So your cervix cannot clear the HPV, and it's the persistence of HPV that can then start changing the cells of your cervix. And HPV is a very lazy virus. It does take a while, but if you're not clearing it, it's just going to hang around. And if you have one of the strains that are a little bit more malignant, like 16 and 18, your dysplasia or the abnormal paps are going to happen sooner.
Right. Right.
We see in my practice, I'll see HPV associated like throat cancers. It's actually not
head and
that
neck,
uncommon, head and neck cancers, and they're actually fairly treatable for the most part. They respond pretty well to treatment, although obviously you'd like to not get that. But the HPV associated cervical cancers, how treatable are they? I mean, I guess most cervical cancer really is HPV associated.
Yes.
Do you ever see it where it's not HPV associated, or is that really not the case? Or is it always HPV associated?
It's mostly HPV. I mean, even so the cervical dysplasia are the squamous cells, but even some of the other cells is more like HPV 18.
Yeah. So we really can't compare it to say whether it's more or less treatable, because they're pretty much all, for the most part, HPV associated.
Yes.
But there must be some strains, like you've said, that are more virulent than others, and there are differences between the strains, of course.
Yeah, correct. Because you can have a negative PAP, right? Over the age of 30, we look for two things. We look for abnormal cells, and we look for the presence of HPV.
Okay.
So there's a scenario where the PAP is negative, the cells are fine, but the report came back positive for HPV 16. So at that point, she's going to need something called a colposcopy, where we just look at the cervix up close under magnification, and we still take biopsies, because you can still have a dysplasia without abnormal cells. So we always just want to make sure that that level of safety, because the PAP is a cellular diagnosis, whereas the colposcopy is histology. So that is tissue. So that's a little bit more sensitive. So even if the screening came back negative, but you tested positive for the virus, we still want to be vigilant.
So if a woman is HPV positive, does that change her screening down the road, or is it still a are they getting PAPs once a year, or they have to be examined more frequently?
So women need an exam every year, and we don't necessarily have to do a PAP. The PAP, the timing of it is kind of you want to look at her history. So women who've had a LEAP, which is a procedure that we do in the operating room, where we just shave a piece of the cervix off when you've got the dysplasia now. So like a CIN2 or 3, that's the cutoff. So these are all precancer cells. But once you've done that procedure, the LEAP, I tell women you need to have a PAP for the next 20 years because they are at risk for cervical cancer.
You know, I love sitting here listening to you because I'm hoping that it gets everyone on board with getting screened, because you cover so much during that annual visit that just won't ever get looked at if they don't go. And it's such a strong preventative measure to take, especially when you see everything that's going on with people succumbing to cancers.
Right.
You know.
When do women stop having PAPs? I mean, I kind of know the answer to this, but for our audience.
Sure, of course. So 65 years old is the time when we consider not doing PAPs. In Canada, where I'm from, you know, they extend it just a little longer. Again, it's a conversation. I mean, I tell patients, you know, there's no PAP police out there. I mean, we could do PAPs. But some women do want that reassurance.
Yeah.
They do want the reassurance. But again, if they've had a LEAP when they were, you know, 57, you know, we're going to extend that screening just a little bit. And if a woman has a postmenopausal bleed, I will do the PAP regardless of their age.
Okay.
What about for the breast screening, like the mammograms? Does that have an end date too? Is that 65 as well?
That's a little later in the 70s. And it depends on her health. Right?
Yeah. I mean, what I usually do is if they have a life expectancy of 10 years, then I recommend a mammogram. If they have comorbidities such that I don't think this person will be with us in 5 years, probably don't need it. I don't know if you look at it the same way, but that's
absolutely.
how.
Yep.
And I look at it that
Absolutely
way
right.
with, you know, colorectal screening and all, cancer screening and all that too. You know, usually we'll stop that at age 80, sometimes younger if someone is not healthy. But that's another important thing for women to keep in mind, is that they have to also think of the other things, right? Like colon cancer and, you know, not smoking because of the risk of lung cancer. All of that, I mean, women are affected as much as men with those diseases also.
Yeah, screening is very important. I agree with you.
So getting back, well, before we get back to the birth control topic, how does obesity figure into all this? Because certainly our country is challenged with rising obesity numbers. So does that change any of the screening or anything that you think about, or, you know, make you think, oh, she needs some additional things to check, or does it put someone at risk for more? How do I phrase this?
You're asking if they're at risk for certain cancers more, or disease processes?
All of that, I guess.
Like endometrial cancer and all that with obesity.
Absolutely. Yes. So endometrial cancer. And the reason is because adipose tissue or fat tissue is an endocrine gland. So it makes a weak estrogen. And that estrogen gets converted to a testosterone. So the estrogen is what feeds the lining of the uterus. So if you have uncontrollable estrogen production from the adipose tissue, it's going to affect the uterus and puts you at risk for uterine cancer. So you're absolutely right. Yeah, that's always kind of on my radar. When we do like a uterine assessment, if I'm worried about uterine cancer. And the uterine assessment is a very small pipette where we go in and we just collect some cells from the uterus. It's very quick. We do an
So it doesn't
ultrasound
sound like
also.
anything really hurts a lot.
No.
You know, just for someone who's maybe hasn't been vigilant with the exams and nervous about going. You seem to put people at ease very quickly.
I hope so.
So, you know, I don't think that there's probably anything to fear going into the office.
No, there's nothing to fear. And, you know, there's a plan for everything.
Yeah. That's good. That's my life motto. Got a plan for everything. So circling back just to the birth control. So we talked about the IUDs. We covered a little bit on the pills.
Yes, so thank you. Yeah, so the LARC, so again, it's the IUD as you mentioned, and there's also something called the Nexplanon, which is a little 4-centimeter rod.
And what's that called then?
Nexplanon.
Next one.
So it's an implant, 4 centimeters in length, and it's very thin, and it just lies underneath the arm, and that's good for 3 years.
Oh. Huh. And that you just do that in the office?
Yes.
You just like, boom.
Yep.
And I'm good to go for 3 years.
Some of our family practitioners in our office do that. It's
Oh, yeah?
it's a pretty simple procedure. I don't do it, but from what I gather, it's fairly simple.
So, like side effects with these, with like the IUD or this that we just talked about that I can't pronounce. Is it the same as if I took a pill every day for as far as side effects or what, is contraindicated?
So with the IUD, there's not many contraindications, but one of them would be, an active cancer, any uterine abnormalities. So sometimes, if there is like a fibroid that's distorting the uterine cavity, then
Yeah.
that would be a contraindication to the IUD. You'd want to rule out cancer, of course, but there are some pre-cancer of the uterus that you can put in an IUD, but I always defer that to my colleagues, my gynecologist colleagues, if we do see, abnormal cells like EIN in the uterus or an adenocarcinoma in the uterus. So that would be, one contraindication, but
Yeah.
it does have an application. The IUD, you can't have abnormal bleeding for the first 3 months, 6 months, but the bleeding
Yeah.
does get less and you may not get a period because that progesterone thins that lining out so well. The Nexplanon can have abnormal bleeding, and that's systemic, right? So the IUD just works locally.
Yeah.
At the level of the uterus. With the Nexplanon, like the pills, it's systemic, so it can affect from head to toe. It gets absorbed by the bloodstream and it gets distributed.
Okay. So with the IUD, is there any increased risk for tubal pregnancies?
Yeah, so you're unlikely to get pregnant with the IUD,
Okay.
but you are at risk if you do get pregnant that it is in the tubes.
Okay. But nothing that you're overly concerned about. It's a safe product and everything.
Yes, absolutely. It's very safe. And that is first-line birth control. For the American College of Obstetricians and Gynecologists,
Okay.
this is what they recommend, or the LARC, so the IUD or the Nexplanon. Because as you were pointing out towards the birth control pill, we take user error out. Because it's hard to take a pill every day.
Yeah.
I mean, you have to have it with you. And they're
Right.
very unforgiving. I mean,
Right.
if you're late by a couple of hours, you'll get the breakthrough bleeding.
Really? It's that sensitive?
Yeah, so you have to be very
fuckers.
vigilant, and every day, same time every day, I tell my patients.
I mean, probably a good percentage of my patients, I don't know the exact number, they forget their blood pressure meds, their cholesterol meds. I can imagine it's the same thing with oral contraceptives.
You work different shifts and you're all messed
Yeah.
up. Like I don't
Absolutely.
take my pills the same time every day. I probably should, but you're not going to set your alarm if you're sleeping.
Yeah, and the contraindications to the birth control pill would be anybody who's had a blood clot in their leg that went into their lungs, any migraines with auras because they're at risk for a stroke. So if patients aren't sure and they have debilitating migraines, I have them see my colleague, the neurologist, just because the migraines with auras is a very specific diagnosis.
Right.
But we just want to make sure that we're not giving them something that could be harmful.
Now, I had seen that they have a patch too. Can you talk a little bit about that? How do you like that?
So the patch, you change that every week.
Okay.
And then so it's 3 weeks on, 1 week off.
Okay.
Or the vaginal ring is also very convenient too. So that's just in the vagina for 3 weeks.
I'm not familiar with the vaginal ring. So what's that and how do you use it?
So that's with estrogen and progesterone, and it's like a little circle.
Is
and
it self-inserted?
Yeah, yep.
Oh.
Yeah, you put it in yourself.
Okay.
So you don't have to think about it every day. It's every
Yeah.
third week.
Yeah.
Interesting.
Yeah. Well, I like all that. So how come with the birth control pills it's not like 100%? Because of the sensitivity and user error?
Yes. Yeah.
All right.
Yeah, that's one of them. And then the progesterone only pills, so that doesn't, if a woman has a contraindication to the estrogen, so high blood pressure or blood clots, you can give them a progesterone only pill, and that you have to take every day, so you don't get a break from that one, and that is a little less effective because you're not suppressing ovulation as well as you would with a combined oral contraceptive.
Now, I'm going to ask you some mythbuster questions. I'm on my period. I can't get pregnant. What are you going to tell me? True or false?
It depends. I mean, are your periods regular, right? If you have abnormal bleeding and it's irregular, you don't really know. You may not be ovulating, or you are
Right.
ovulating, so you wouldn't know.
Okay.
So I would, barrier method condoms. I mean, if you're not ready to get pregnant, then you should be on something.
Okay. Second question. The rhythm method. Some people use it. Effective or not?
So it's not as effective as what we have out there. There are some really great apps that can track your menstrual cycle. I like Ovia, OVIA, and that will tell you where you most fertile. So I provide that for women who are trying to get pregnant as a tool, but I don't recommend it if you're not trying to get pregnant.
And Dr. Roy, with the literature that's out and some of the research that's being done right now in a variety of topics, what's exciting you the most? Like, are you tracking anything or any certain treatment that's kind of cutting edge that's out there now that you're like, I can't wait for this to kind of
I think
trickle down?
more, I think the surgical aspect of it. So, we've talked a lot about medical
Yes.
management for bleeding. But for some women, we just can't control the bleeding medically. So then we take them to the operating room. That's always an option, where we just take the uterus out and we can leave the ovaries in for, younger women. But if they're older and they're worried about, ovarian cancer, then again, it's always a discussion with the patient.
Right.
So for me, I like the robot. I think that is
Yeah.
really cutting edge.
That's really changing surgery. It's amazing.
It was a big change for you?
It's really changing
Oh,
surgery,
yeah,
I think.
absolutely. Yep.
Yeah, we had Dr. Herman Gildo here the other day.
Oh, yeah, he's
week, and
a great
he was
robotic
he
surgeon.
talked basically about robotic surgery the entire time, and yeah, it's really remarkable how it's gone from being used in one area. I think originally it was mostly urological procedures, if I remember correctly, years ago. But it's now it's gynecological, general surgery.
Yes.
It's really remarkable.
It really is remarkable. Yeah, it's an incredible technology.
Yeah, it
I
really
agree.
is.
Yeah, and women have less pain with the robotic hysterectomy. It really is groundbreaking.
If a woman has doesn't want to have a hysterectomy for whatever reason, and there's probably a lot of reasons they may not, and they want to do like an endometrial ablation for excessive bleeding. Tell us about that. I see that once in a while offered, and I don't really know much about how it's actually done.
Yeah. So
Is it done much at this point, or is that less?
Yeah,
common?
it's still done. The thing with the endometrial ablation is that you're burning the lining of the uterus. It's for women who have heavy periods, so you can take them down from heavy periods and normal people periods. And some women have no periods, but that can't be the end goal because it may not be achieved. The only issue is if you have the bleeding decreased and then maybe 3-4 years down the road it increases again, and then I'm worried about a uterine cancer. It's quite difficult to get that pipelle in because everything is burned and there's adhesions.
right. I never thought about that.
So it's hard to get back in. So that is one modality that gives me a little pause.
Yeah. I don't see it a lot, but I do occasionally see a woman have it done, and I was just curious about the
It is a
procedure
tool
itself.
it's a tool in our toolkits.
With the conversations that you have in the office, what is some of your most common questions that people worry about or that they'll ask you?
So I think bothersome periods, their menstrual cycle, and I tell them, if it bothers you, it bothers me. So let's, we have options, and they want to know if that's normal. vulvitis, itchiness. I think one topic we didn't cover would be the postmenopausal woman with vulvitis. So, very itchiness that keeps them up at night. And that can be a condition called lichen sclerosis. But again, you always want to rule out cancer. So that's easy enough to do with a little biopsy. I do it in the office. I just freeze the area with lidocaine, and they don't feel the biopsy itself. But if they have lichen sclerosis, then that is something very easy to treat with a high potency corticosteroid that they just put on the vulva, and they feel so much better.
It's really great. Like, so many of these things and these issues that women face are easily treatable.
Yes.
It's not like it's a big, long treatment process or messy or anything like that. It's like, yep, you have this, boom, here you go. And that's a great advantage of just keeping on top of everything.
And like you said, a lot of this treatment is not uncomfortable in any way.
No.
But a lot of women probably still do avoid going into their physicians or their gynecologists because they have fears and concerns.
And it's the unknown.
And men are the same way with other things, so it's important for, I think, everyone to know that, a lot of this stuff is common. They're not the only ones who suffer with whatever the complaint may be, and it's treatable and very often easily so.
Yes, yeah, exactly.
So as we kind of round out this discussion, what's the one biggest message you want to give to our viewers?
As Dr. Joncas so eloquently put it, is preventative medicine. We really do want to get ahead of things and of disorders. So get your mammograms, your cervical screening, and, just your health, your screening is very important for women. And any questions that you may have, no question is too small. It's, as physicians, we've kind of seen it all, and
Sure.
we can definitely help, or we can find someone who can help you.
Yeah, if we don't know the answer, we can find someone who does.
Yeah, exactly. Yep. At primary care, we've got a lot of specialists, subspecialists, and we all work very well together.
Yeah.
It's very collegial.
Absolutely.
Place
Seems
to
like it,
work.
yeah.
So
Yeah.
I have no problem. Dr. Joncas sends me a text message. What do you think? Can you see this patient? And we really do work closely together.
Yeah.
So, as he said, if we can't answer the question ourselves, we'll find someone who can. Yeah.
That's great. Very good. Well, this is a wonderful conversation, Dr. Roy. Thank you so much for participating and being part of this. I want to thank, of course, Bay Coast Bank, which is right for all your financial needs. Visit baycoastbank.com or call 508-678-7641. If someone wants to get in touch with you, how do they get in touch with you? And we'll post this also. But
Oh, sure. Yeah.
how do they call you?
So the number for my office is 508-673-1033. And my scheduler is very responsive. She's great. All messages are returned, and we
Great.
check our voicemail several times during the day. So you will be able to get a hold of the
That's
office.
great.
Yeah.
Well, I want to thank you. This was really informative.
Thank
It was
you.
great. I'm
Thank
sure
you
that our
very
audience learned a lot. I learned a lot.
I learned a lot.
Yeah, it was wonderful.
I think so too.
So thank you very much, and I'm sure down the road we'll want to have you back again to do part
Appreciate
2. So thank you. Appreciate it.
Thank you.